So welcome to our session on precision medicine and what we need to think about when we think about implementation. I'm very, very happy to welcome our panel here. I'm not so happy that I have to excuse Sarah Garner, who is, as per the program, our moderator for this session, because she unfortunately is not doing well and she was not able to join us here. But she sends her greetings and she hopes that we will catch up with you the next time. My name is Dimitra Pantelli. I work with the European Observatory on Health Systems and Policies, and I have been given the honor to be the moderator in Sarah's stead, and I hope I will do her justice. Now, before we start with our session today, a big thanks already now to Tarang Sharma from WHO Europe, who has been instrumental in putting the panel and the content together. And she's here if you have any questions about anything or you don't like anything. She's the one that you need to talk to. No, of course, I'm joking, but just to say very many thanks, Tarang, for everything. All right, so precision medicine, it's why we're here today, is an innovative approach to tailoring prevention, diagnostics, and treatment that takes into account the differences in people's genes, but also environments and lifestyles. It's an innovative approach. In some countries, it has been in development over many years. In other countries, we're now starting. And while it has a great potential to increase the effectiveness of care, the efficiency of care, quality of care for patients, and contribute to personalized care the way that we've been talking about the past 2 days, it does not come without risks, and also it needs sufficient investment in both infrastructures and upskilling the workforce, and of course that means also sufficient funding, which needs to be, of course, traded off with funding in other areas. So we have a stellar panel with us today who will give us their reflections on this issue, and we'll start with Matt Boltz-Johnson, who works with Eurordis, and he will give us a perspective from the patient side. We will then hear from Sander Pausalu, sort of okay, I hope, who is the head of the Genetics and Personalized Medicine Clinic at the University Hospital here in Tartu, in Estonia. And he will talk to us more about the workforce skills, I think. And both of our speakers, Matt and Sander, will have short presentations. And then we will have a panel discussion with Ingrid Schmidt from Sweden, with Helen Brandstorp from Norway, and with Thomas Olvin from FPA. And hopefully we will have a little bit of time to have discussions also with you at the end of the session. Without further ado, I will pass the floor to Matt to give us his introductory thoughts. Thank you.
Thank you. I have to stand over here if that's okay, because I've only got one hand working today. So thank you very much for inviting me to speak today at this conference. I mean, I must admit, it's been brilliant. I've only been here today, but the previous session on financing was an eye-opener. I used to work in the health system in the UK as a regulator, so it was really refreshing to hear that discussion about health finances. First of all, I would like to just set the scene with precision medicine. The term precision medicine has been used, and there's lots of other terms used around personalized medicine, stratified medicine, precision health, genomics medicine. And we all use them in different situations, and in certain countries, because of the policies around it, they mean specific things. But overall, they mean the same thing. Using them interchangeably makes it harder for us to leverage this innovation across Europe and have an orchestrated approach around it. Precision medicine goes from prevention through to diagnosis and treatment. And it's important that with precision medicine, it's about identifying a specific gene or variant that is identified and targeted, and that can result in securing the right diagnosis for the right treatment at the right time. Precision medicine has initially been focused on cancer, rare diseases, and infectious diseases as well. But the visibility of a strategy on precision medicine has been progressively replaced with a strategy around genomic medicine. Precision medicine, the applications of genomics is transforming healthcare, and we're seeing that across Europe, and embedding genomics across the continuum, healthcare continuum. This results in different branches of precision medicine or health. From genetic risk and screening through to diagnosis, pharmacovigilance, genomics, precision medicine, and precision public health. Rare diseases are an ideal entry point to applying genomics into healthcare systems because there is a high signal-to-noise ratio to identify the causative gene. 72% of rare diseases have a genetic origin, and it might surprise you that for rare cancers, actually, the total number equates to 20% of all cancers, really. So rare cancers alone is covering a bigger population than any one other single cancer type. So the idea of using rare diseases and rare cancers, it's an ideal entry point into using genomics into healthcare. Precision screening enables us to identify, get a diagnosis early. Population screening isn't necessary precision screening, but when it comes to rare diseases, newborn screening is, and there's a move now to genetic newborn screening, and that's at the research stage. So we're on a fast, accelerated path now to introducing quite innovative technologies, which potentially, if implemented individually in different countries, could create huge inequities about what conditions and genes are included in the panels. I wanted just to do a call out for hereditary screening. It's one of the most clinically and cost-effective screenings for rare and ultra-rare diseases for genetic tumor risk syndromes, which enable you to get access to treatments which are really effective. In rare diseases, we have two populations, undiagnosed and those yet to be diagnosed. When we look at the undiagnosed population, not everyone needs to have whole genome sequencing. You can use different techniques of genomics to identify the causative gene. And in a way, there's projects called SolveRD here, which are trying those proteomics and different types of technologies to see what works and to learn. So this field is developing fast. So to the medicine bit, the precision in precision medicine involves identifying the gene target to ensure that we get an accurate diagnosis, but to really enable that we optimize treatment pathways. So not all precision medicine are high cost. With rare cancers in the UK at the moment, there's a study going on where they're looking at using existing treatments off-label or repurposing to treat rare cancers, and that's been very effective. That's a determined study. So with precision medicine, it can also involve small and large molecules, advanced therapies, which I'll talk about a bit more now, and also gene editing. For a lot of these ATMPs, as we call them, there can be a small window, a treatment window to enable people to access that treatment, and SMA is one of them. And if we don't have a timely diagnosis, then we're unable to access something which is potentially curative. We have around 60 ATMPs at the moment approved, and there's a big pipeline of around 1,000 clinical trials happening globally. But the whole debate on advanced therapies and precision medicine at large has been around the affordability of these therapies. And actually that overshadows the need for investment and looking at how health systems can be better supported to adopt these therapies. There's learnings from the UK we can get from the therapeutic catapult, which I think is brilliant. And where you've got the whole healthcare system being the main purchaser, but building the infrastructure to enable when a therapy comes in, it can be adopted quicker, and having that discussion with pharma companies to standardize those therapies so they can be stored at the same rate, etc. We need a different model of care around this, a centralization of cases and optimizing infrastructure. And we need to develop more around the workforce, which my colleague will talk about in a minute. So we've got 4 building blocks to applying genomics and transforming our healthcare systems. The first one is around engaging with the communities and building public trust. When we're talking about precision medicine, we're talking about large amounts of data, personal data. We need to know how it's going to be used, how it will be stored, what it will be used for in the future. And trust is a key theme to this conference, and it's something which we need to look at as a first step. Application of genomics as well, we need to also look at primary care and the skilling of primary care as well. In rare diseases and and cancers at large, stigma is a big issue. If people aren't going and looking for this and coming forward, there's a lack of awareness. There's a delay in getting a diagnosis. So we need to ensure that we need to tackle stigma as a starting point. The Novel Medicine platform, which is being developed at the moment, creates a unique multi-stakeholder environment to ensure that countries exchange knowledge across Europe. And of course, it's important to connect experts, to connect infrastructures between countries so we can learn and so we can leapfrog forward and have an accelerated starting point for rare diseases and cancers in other countries. I just want to end on a quote about trust, because it's a conference about trust and transformation. Genomics is at the heart of transformation in healthcare systems at the moment. So this I really like. Nothing is as fast as the speed of trust. Nothing is as fulfilling as a relationship of trust. Nothing is as inspiring as an offer of trust. Nothing is as profitable as the economics of trust. And nothing is more influencing than a reputation of trust. That's it.
Thank you very much, Matt. This was really eye-opening, I think, and a very nice way of organizing all the different components. And it's really crucial to show the potential across the continuum of care. If I can build just on the last point on trust, I think we were talking yesterday about this notion that it comes in on a tortoise and leaves with a horse. So it's really interesting, it's really important to foster it and then take good care of it. And I think specifically when we talk about precision medicine, because of the large amount of data that is required, and some of it really sensitive data like genomic data, this is something that we really need to bear in mind and be careful about, because patients need to be able to trust that their data is secure and that they won't face discrimination because of the data that is collected. So it's a really crucial point. Thank you again. Moving perhaps from the overall perspective and setting the scene and the crucial point on trust to the workforce issue. We talked about this a little bit in the beginning, the significant requirement for upskilling, Sander, on digital literacy, on understanding biomarkers, on a number of different levels. So perhaps you can give us the Estonian experience on that.
Yes, thank you very much. And really thank you for all the organizers for inviting me here. And it's a great honor to be here and to share a bit about Estonian experience and also my personal views on the topic. I'm trained as a medical geneticist, so I'm an MD, PhD, and I have been working in the field of clinical genetics for the past few years already. And currently I'm also head of genetics and personalized medicine at Tartu University Hospital, so I'm administrating the unit in Estonia, the clinical unit, which is responsible for delivering clinical and laboratory genetic services to the whole country of Estonia. So we have outpatient clinics in Tartu and Tallinn, and we serve the whole population in that sense, or at least vast majority, and especially regarding rare diseases, which we also heard about. It's always a bit difficult to introduce the topic as a second speaker, so I'm trying to adjust here. And the first slide is actually not about workforce, but my personal views on precision medicine. And usually the basic ideas what people think of as when they talk about precision medicine or personalized medicine is that we somehow agree that people are different, therefore their diseases are different, and different diseases need different treatments. And we usually do not challenge this idea, because this is something we have been quite on the same page with. But as a geneticist, I want to remind you that we are 99.9% similar, at least genetically speaking. And so every 999 nucleotides in our genome, on average, are the same, and 1 in 1,000 is different. The second sentence or idea, it was already mentioned by Matt, is the basic idea that we want to give the right treatment for the right patient given at the right time. I cannot challenge this one. I totally agree. But the last one is that when attending to the conferences on precision medicine and personalized medicine, you often hear that precision medicine is challenging the ways we think about evidence-based medicine. That it's kind of like the next step, because there is a critique that randomized controlled trials and those methods we have learned and used since the evidence-based medicine came along are not perfect because they do not take into account the differences between ourselves or between individuals. And that's why often it is said that precision medicine is the next level, and we have now the N=1 trials and things like that, which is very hard to do in the old-fashioned way to reach some kind of statistical significance. But I would say that we still need evidence, and this has not changed. And we need to be very, very consistent that we do not implement things which are not evidence-based. The other question is how we generate the evidence, but we still need evidence, and I want to emphasize this a lot. Okay, so what do we need in order to precision medicine or personalized medicine to happen? Many of those things were mentioned before as well, but I'm trying to give a bit of a different perspective here. Of course, the first thing we think about in genetic or in personalized medicine is data. We need data, but it has to be of clinical quality or medical quality to be usable in healthcare. It has to be stored somewhere where we can access it, and it has to be interoperable and reusable. It seems like a very simple thing and something that is like obvious, but how medical labs currently work in many places is that because they are getting paid by the service, then they are not actually interested in storing the data and reusing the data. But they are actually more interested in producing the data again and again because that's how they make their profit. And this is something we actually need to address if we look at the healthcare system as a whole. Okay, but then the data itself is just the data. It's not like a medical actionable just being data. So we need something that can handle the data. And of course, the data is very well handled by computers, so we need medical devices, which often nowadays are actually software devices. But these need to be valid, certified, and they have to do the right thing. And that's where actually the key component in the precision medicine, I would say, is the medical device manufacturers. So the startups and also established manufacturers who are able to make those devices and to certify them and bring the knowledge and ideas from academia to healthcare and kind of resolve the implementation gap, which is very present in the field. But then, okay, we have the data. Perhaps we have a good and working model about risk prediction for some particular disorder, but nothing really happens before we are agreed on what to do with that risk in the healthcare setting. So this is the next step. So one may know that he or she has, let's say, 20% higher risk for type 2 diabetes, but what should a doctor do with that information? And this needs to be agreed upon in every healthcare system and also be reimbursed, so the next activities. And then, of course, we need workforce. And this is obvious, and we do not only need the doctors, we need also all kinds of different specialists. Currently, I'm really struggling in getting bioinformaticians to the hospital. We are talking about introducing genetic counselors to Estonian healthcare system. We do not have them at the moment. We have medical geneticists, but not genetic counselors. But there are so many different specialties, health coaches, data specialists, data security specialists, you all need for successful implementation. In Estonia, the previous project, which now ended, but it's still ongoing, or finished, but it's still ongoing, built an ecosystem or an IT infrastructure, which tries to make use of the fact that in Estonia, more than 20% of adult population have their genotype data available through Estonian Biobank. So more than 20% of adult population is participant in Estonian Biobank, which is part of Tartu University. And now the idea is how to bring that data into healthcare. It's not an easy task, but many of these steps were solved during this 5-year project. But straight from the beginning, the idea was that we do not want to discriminate those people who are not in the biobank. So we want to give the same services to whole population. And so some of the people may need new data to be generated in medical lab, but it has to be in the same formats and usable in the same way as the biobank data. And then it will be stored in the national health information system, where there is now a subunit called genetic data information system, which is linked to computation environment, and this is where the software-based medical devices can do their work. And in the end, the recommendations should end up in our centralized electronic health records. So this is kind of ready, but then and the first service we are trying to get into live action would be a precision breast cancer screening, but it's very close, but not live yet. And now to resolve the implementation gap, so to get the ideas from academia into medical devices, we are now building a new center for data-enriched medicine. We got a big EU funding and funding from Estonian government as well. And this is in cooperation between Tartu University and Tartu University Hospital. And we have also partners from Helsinki University in Finland and Erasmus Medical Center in Rotterdam, the Netherlands. And very much hoping and looking forward into this action and getting it the real effect on healthcare as well. Okay, and to conclude, I'm a bit over time, but I see a personal genome as a resource, and as a resource on very many levels. So it's a resource for individual, for those reasons that also Matt described very well. It's also a national resource, how we can tailor our healthcare system to bring our resources for those who need them the most. And especially in the rare disease world, it's also an international resource. We really need international collaborations for making or to discovering new aspects about rare diseases, because there is no country big enough to have the data there. So we need international collaborations. And I want to end with the point that we need also realistic expectation. Genome is not everything. We cannot solve everything by just sequencing everyone or doing some fancy genetics tricks. But the realistic expectations are really the key in successful implementation. Thank you.
Thank you very much, Sander, for the critical, I would say, and sort of nuanced presentation, and for highlighting the importance of exchange and collaboration. I think your slides on the current initiatives was really packed, and I think a lot of us would be really interested to hear a bit more about what they entail and what they will do. But I know that, for example, Matt also has worked with the European reference networks in the past, and colleagues also in the panel have had experiences like that. So there are a lot of different avenues for working together, and clearly it is absolutely necessary. So thank you for that. We'll come back to you and to Matt later in the session. We move now to our panelists. And we start with this notion of countries working together, perhaps in a more circular way. We had, in the first half of this year, the Swedish presidency of the Council of the European Union. The presidency rotates, and different countries have it for 6 months at a time. And Sweden had personalized medicine as part of its agenda. You, Ingrid, held a really big meeting in June, thinking about the benefits and the challenges of implementation for personalized medicine, and exactly reflecting on some of the things that Sander was talking about the position of precision medicine within the overall personalized care approach. So would you like to tell us a little bit about where Sweden put the focus in this area during your presidency?
Yes, thank you, Dimi. And we did that together with you. From system approach. We really
remember I'm Sarah, right?
Yeah. But first of all, thank you for being able to comment on this, and thank you for a great presentation. I was really encouraged by your conclusions on what is possible and what is realistic and what we can do also. I work in the National Board of Health and Welfare in Sweden, and we have thought a lot about what it means with person-centered care. And person-centered care entails a lot of aspects, which has to do with also how you meet the patients, how you talk to the patients, how you encourage them to promote their own health, with taking account the placebo effect, which we know a lot about now more, and how genes and the psychological behavior kind of interact. And I was also very inspired by one of the patient story in the beginning of the conference, who thought she was almost dying, I think. But had a really interesting journey within the context of really person-centered care, because she had the lack of meeting people that helped her to find her passion in her recovery. And I just want to remind of that perspective when it comes to the whole scene of what person-centered care is. And we also know that by using the evidence we have to promote people's health and change behavior, we have a lot of evidence of quite simple measures that we could also use in healthcare. And at the conference during the Swedish presidency, the goal was to put this whole concept in context of the system and what the system challenges really look like at the moment, with this increasing number of people with chronic diseases that we need to prevent. So we need to work with primary care and how to develop prevention and health promotion in primary care. And there are different models for that could be used to actually achieve equity in health through a person-centered approach, and where personalized medicine is a part of that. And as a background in pharmacy, I mean, this is the dream, of course, to find the exact right medication for each person, but it's maybe a little bit of a utopia. There are many factors influencing how medications are delivered in the body, etc., and it's influenced by many factors. And to have the genetic information is a tool to get some more knowledge. And in Sweden, as in rare diseases, cancers, that's where we see the benefits right now. Yeah, there was some comments, and it relates to your last conclusion there also. And we will, together with European Observatory, we're working on a brief, a policy brief, which will conclude policy recommendations in how
options,
to handle this area in relation to all other also system challenges that policymakers needs to consider.
Yes.
So that's somewhere, but
Yeah.
so that's the work we did with you, since we want to have the meeting put in a system context.
And I think that was crucial. And maybe just by now you've all seen the observatory policy briefs. They are the blue books that we've been handing out during the plenary sessions. This one is still in the making, so it's not around, but it will be around. But it will be around. And I think just to weigh in very quickly before we go to Helen on what Ingrid said, I was originally supposed to be a panelist, so I'm going to take 30 seconds to just weigh in on that. What we saw really nicely at the meeting in June was this understanding of going beyond the focus on really costly specialized treatments for specific diseases, and this is also what Matt was talking about, that we have a care continuum that we need to think about, thinking of prevention, how that works with a precision approach, what that means for non-precision approaches, thinking through very carefully all the ethical considerations that come with implementing personalized approaches, from the potential for data discrimination to exacerbating perhaps inequities in different areas, but also within the precision medicine paradigm, over to the different infrastructural needs that are needed, from, let's say, laboratories over to different types of skills, and then, of course, evidentiary requirements and where the study designs come in that Sander was talking about. And then finally, of course, seeing as this was the presidency of the Council of the EU, what the EU has been doing and has done, for example, in terms of the regulatory framework, and how the different components of the European regulatory framework, like the GDPR and the European Health Data Space and the IVDR, how they all fit together and challenge and or enable precision approaches. So we will be back with more on that when the policy brief is ready. And we can discuss this more if we have time at the end of the session today. So thank you very much, Ingrid. Helen, over to you. Sticking to the north, we have some lessons to learn from Norway when it comes to implementation of precision medicine. So perhaps you want to let us know what they are. We did not work on that together, by the way. Disclaimer, this is just you. Okay.
Thank you. Thank you for having me on this panel, because I'm not the expert. So thank you for your contributions. I came to personalized medicine or precision medicine 4 years ago only, from primary health care research and being a GP up north in Norway. But 4 years ago, I was given a position in the Directorate of Health in Norway, working for the government, as a chair for the professional board for personalized medicine. So what I will give you is my kind of anthropologist perspective, I guess, on the Norwegian way of implementing this expensive and very interesting form of medicine. What I saw was an unusual attitude of collaboration, really. And you know, as Norwegians, we tend to live isolated and we want to work alone. But suddenly, this strange form of collaboration and humble way of collaboration. Why is that? I think it could be because, you know, the data is scarce. You have to collaborate. So that's one component. The other thing is that it's kind of a new field. Exploring together feels more safe than exploring on your own. So maybe that brings people together. And then there is costs, infrastructure, and everything. Building on this attitude of collaboration is networking. Very interesting to see how the governmental professional board that I was, you know, given the chance to chair as a newcomer, it has been there since 2017, and it will continue. Interprofessional, with lawmakers, with ethical experts, with primary health care, specialized care, researchers, with industry, patient organizations, and professional or the organizations of professions. This was mirrored. This governmental structure was mirrored, or is mirrored, by the healthcare service itself. It's building a network that's growing, and it's nurtured by researchers and by clinicians, by this spirit of collaboration, and it's really huge, and it's humble. So the specialist in Oslo would say to the media, "I won't answer that question. Please pose it to my colleague up north." So he could, give the answer and, be visible for the network, for the country. Yes, it's not. I mean, wow. It's just my view on it. And the network is, of course, going abroad to the Nordic countries and also to Europe. 1 million genome. We're too small. We need all the ideas we can get, all the networking that we can make. And the third thing is that there has been a strategy, and there is a new strategy from the governmental level. And the current one, for 7 years, has 3 strategic goals. The one is, I think, in the same vein as attitude of collaboration. It is equality in access to personalized medicine with close integration of patient care, research, and other types of systematic generation of knowledge. The second one is healthcare services that possess the relevant competence to meet individual needs related to personalized prevention, diagnostics, treatments, and follow-up. And the third one being safe and efficient use, analysis, sharing, and storage of large-scale health data needed for personalized medicine. So yes, I think that's what I wanted to bring to the panel, this phenomena of collaboration. Maybe it's like that in every country. To me, coming from primary health care, and it was not the same. So I hope it's the same in every country, and that it's the new thing, and it's bringing people together. At least we are together. So
that is very true. So thank you for that, and thank you for the different components of implementation that you brought in. Very clearly for me, stakeholder engagement, very clear strategic direction from the leadership side. So these are themes that we will pick up in the upcoming plenary, exactly on this notion of how we make change happen. If you had asked me before you started talking, where do you think we have more humble collaboration, in primary healthcare or in precision medicine, I would not have picked precision medicine. I don't know how others feel. But I'm happy to hear that there is this paradigm, and I think we all have a lot to learn from it. So perhaps we discuss this a bit more in a minute. But thank you very much. This is really, really useful. Thomas, we come to you, last but not least, with a perspective from the industry. You heard already quite a bit on the different resources that need to go into the system, on the different potential, the huge potential that this approach has, on the different considerations that temper it perhaps a little bit. How do you see it?
Yeah, thanks so much, and thanks so much for inviting me to this great panel. I think some great presentations and perspectives already to build on. I think looking at this topic, and I would go back to actually the outcome statement from this conference that was adopted yesterday, and because I think it contains a lot of building blocks that are very relevant here. One is, of course, the investment part, investing in health, which came through very clearly. There's also another element at the beginning of the statement that talks about there are challenges with overuse of medicines or inappropriate use of medicines, and this is a challenge. And then I think it ends with talking about this, the right care to the right person at the right time. And I think all of these things actually come together in precision medicine. Because I think it's clear that to make this happen, you need to do certain investments, and those already been talked about. But you need to invest in the testing. You need to have biomarker testing, genomic sequencing, maybe AI tools. There are machine learning tools that are used in this field. Of course, the data infrastructure, all of that that's been mentioned. This requires some upfront investment to make this work. But if you do that, you will actually deliver better health outcomes and can actually save costs over time. And I think, and that also goes back to the previous plenary session, and I heard some people say, well, maybe we shouldn't invest more in health or whatever. I came in late, so maybe I missed the point. but yes, it is about, yes, we need to invest, but we should invest in a smart way on the right things that will actually deliver health outcomes. And I think there's a lot of great examples on that. There's for instance, an Irish example where they used genomic testing to predict which patients with breast cancer, in this case, that would benefit from chemotherapy and who would get a severe adverse event. And by doing that, they could save, just in 1 year, around 800,000 euros. And most of that is just not having these adverse events, because that costs a lot for hospitalization. And in this case, the cost of this test was around 23,000, so it's not nothing. But the cost for the same patient for hospitalization was 230,000. This is by a factor of 10. Mm-hmm. So you save much more than you put in if you can get this more targeted treatment and make sure that you treat the right patients with the right thing. And was another great example from France when it came to patients with non-small cell lung cancer, and where they invested in testing of EGFR mutation to determine who would benefit from a cancer therapy. So one of the new, of course, rather expensive cancer therapies. So they simply would not give this medicine to patients that would not respond to it, because that's the new reality of oncology and now many areas, that you can have a fantastic medicine, maybe it's a new immunotherapy. On some patients, it works wonders, and it's incredibly effective. On some other patients, not at all, or much less. And this is what precision medicine is all about. Sometimes we don't know why it works on some and not others. We need to figure out. But when we do know, we need to use that knowledge. And just by spending 11 million, this was between 2008 and 2014, by spending 11 million on these tests, they saved 460 million on not using this drug. So, and by the way, you should note this, because so I represent the pharma industry, but I'm talking about a model that will lead to less drug spending when it shouldn't be used. And I think because we need to save those monies, we can use, again, for better investment for health. So these saved money should stay in the health budget, by the way, so not on defense. And I heard a lot of other things in the panel before, but let's keep it in the health sector. So in this way we can really target treatments, make sure that they get to the right patient. But again, this will require investment, and I think this is a new. We already talk about equal access to treatment in Europe, and that's a big theme, of course, of the current pharma package when it comes to the European Union, and even more so if you go beyond the entire European region. And that's a real problem we need to work on. But when we get into precision medicine, we also need to talk about the testing and all this infrastructure, because precision medicine is more, it's not so much about the medicine as it is about everything around. And we also looked into, from FBA, the access to high quality biomarker testing in European countries. And also there you can see huge disparities, because, and again, it's not only having some tests, but having a quality test by a certified lab, etc. And here we have huge disparities, and again, investment needs, but also just getting the right structure in place, and where I think countries can again learn a lot from each other.
Okay, thank you very much. I'm going to challenge you in a bit, not yet, because you said correctly, it's not just about the really high-cost treatments, but it's also about the high-cost treatments. And I think we need to really think about the different countries we have in the European region and how likely it is that these treatments will be available, affordable, and sustainably so. But let's return to that in a second. I will ask first Matt and Sander if you would like to reflect on some of the things that you heard. I think a lot of the different impulses from the speakers linked to your experience. Matt, I'm looking at you because we start with you. If you give us a brief.
I think this shared learning shouldn't be underestimated. Some countries are not at the same starting point, and we can leverage the knowledge and experience which has been gained in countries where they've developed these types of things. Like I mentioned before about newborn screening, genetic newborn screening is in the research stage. Not everyone's going to be pushing forward that type of research and development. So having a forum like the Novel Medicines platform enables us to share that learning across and know when something should be worked, and that reduces cost in terms of implementation. So I think for me, you were saying about collaboration was a surprise for you. For me, everything in rare diseases is about precision or personalized medicine, and it's all about collaboration. We're forced to move past this siloed working through necessity. Not everyone has the experience. Professionals at the leading hospitals build up personal networks to borrow other people's knowledge. Have you seen this clinical presentation before? And we've formalised that on a European level with the European reference networks. That's the first proof of concept which globally people are looking at now. So I think, collaboration, we need to extend it beyond the EU. We need to extend it across Europe. We need to develop platforms to enable us to benefit from this and reduce the cost of bringing in these technologies to other countries.
Thank you. So Novel Medicines platform. I think we started years ago with the Oslo Medicines Initiative. We have now the new platform, really promising, so we're all looking forward to that. Work has started in the working groups already, so there will be, this is another watch this space situation. So thank you very much for pointing this out. If we have time later, maybe we can reflect a little bit on the European reference networks, because I think this is an excellent example as well. Sander, we come to you.
Yes, thank you. So excellent points you all made here. I was also surprised with Norway's experience on collaboration. So I hope that I could say the same for Estonia. Well, we have a bunch of people working together, and that's really fantastic. But still, we see that like oncologists think that precision medicine is only oncology, and some other doctors think that it's only for them, and there should be more, not even dialogue or much more communication around that, so I can totally relate to that. And I really like the point about reducing the unnecessary treatments, and this is actually something which is, I find it's really, really true. And that this relates also to the design of clinical trials we are doing. That previously we did a trial, we understood that, well, it works in 50%, and well, that's very effective. But we now can understand why it didn't work in the rest, and they should not get the treatment, and how to differentiate those 50% and 50%. So that's one of the key aspects in my mind too. Thank you.
Okay, thank you very much. Before I threatened the question for Thomas, so I'm gonna follow through with that. But before that, I would like to ask those of you here that I can't see very well, if you have any questions or comments or want to bring in your perspective. Yes, please. We do need a microphone because we have an online component of this.
Thank you very much. My name is Judith Bidlo, and I'm from Hungary. I'm the State Secretary for Health, responsible, and thank you for the wonderful presentation and the comments. It was really insightful. I have a specific question concerning the biobank in Estonia, because we are just planning to initiate one, and I really wonder a very specific question. Two, actually, because there are lots of risks. Do you store the sample itself, I mean the blood or whatever, or you just store the data from the genetic data? And do you planning to provide access for foreign researchers for your biobank. Is it acceptable for the Estonian people, or do you planning? Because these are the questions that has been raised in Hungary when planning a biobank. Because I think it's very, very valuable when you can provide access to researchers, but it's risky on the other hand. So that's and the last and there is no more question. Sorry on that the informed consent that the patient sign is valid for a future provisional research as well, or just a certain, or just they provide then unlimited access to their data or to their biobank. Sorry for the very concrete question, but it has been raised.
Before you start, one moment. Are there any more questions? Because there's already 3.
Yeah.
Related or unrelated? I can't see you very well, I'm sorry. Unrelated. All right, so then we do let Sander answer, and then we get back to the audience for the next round. Related one, go for it.
So building on that, you also mentioned the data enrichment movement, because the personalized medicine needs to go alongside the clinical data. And from what I know, because I'm Lithuanian, I know the Estonians as well, you struggle a bit with the clinical data quality. So what kind of standards or approaches you have to use the clinical data already collected, which is not standardized, and like what kind of standards you see being used in the future? It's not like interoperability of sharing the data between the institutions, but like how you address the quality of data that you already have in clinical data.
Thank you. Sander, you have 3 minutes. Go for it.
Okay, yeah. So many questions are perhaps a bit too detailed here, but I'm happy to discuss later. And just to be clear, I'm not working for the biobank, and I have never been working for the biobank, so I feel a bit uncomfortable commenting on some of the issues. Here is also Riley from Ministry of Social Affairs, who can comment on some legal aspects here. But yes, they do store the samples itself as well, and also like plasma, not only DNA and stuff. But the biobank initiative was started already in early 2000s. And there is a specific law for that biobank in Estonia. And the struggle there is how now to keep up with the new regulations and IVDRs and everything related to that. And perhaps many things, when you start now, you will do it completely differently. The access for foreign buyers of the biobank, so it's regulated, and there needs to be permissions, but and it's pretty complicated at the moment. But under some circumstances, I think it can be done. But it's very regulated. Riley may answer that later on. Regarding the data and how it moves now, it's a longitudinal consent, so they can pull the data from our electronic health records, but it's one directional at the moment mostly. So now we are trying to work on getting the biobank data back to healthcare as well. But yes, it's not very well standardized, the digital electronic health records at the moment. But then again, it's a good task for our IT specialists how to deal with it and how to pull information to also from free text and do some machine learning on that.
Sander, because we didn't have enough questions, are the European projects that you're working on also looking at those questions, or is it more on the Estonian side?
No, so it's a collaborative project, and we are it is aiming to facilitate at least the work towards that as well, and to maximize the benefit.
Okay, thank you very much. We had a couple more points, or at least one that I see. Yes.
Yes, thank you very much for the discussion. I'm Claudia Luetti from the European Patients Forum. I also have a question for Sander. Sorry. It's about your last slide. You had at the very last sentence, I don't know if you actually talked about it, but you mentioned personalized prevention. And I was wondering how you implement that in practice, into our healthcare system, and perhaps, looking forward, how that could happen. We are part of a project at EPF, which is called PROPHET, an EU project, which looks at personalized prevention, and obviously genomics is part of it. But I still have trouble understanding really how we could implement that in practice, at least the way our healthcare systems are currently structured.
Yeah, it's actually a very difficult question. And the last sentence, if I remember correctly, it stated that it's a great challenge, but a great challenge is a great opportunity as well. So actually, yeah, so for example, I can make an example of the planned breast screening precision breast cancer screening. So the idea there is that the first step to do is that every 40-year-old female gets an invitation whether they want to be part of that screening or not. So the regular breast cancer screening with mammography starts at the age of 50 in Estonia. So now every 40-year-old females are given the option to get the genetic score for their personalized risk. And the idea is that if the 40-year-old, due to her genetic markers, has the similar risk as an average 50-year-old, then the mammography screening starts from the age of 40, just bringing it 10 years earlier. So this is the very high-level picture into it. But there is very many challenges. For example, by Estonian law, only GPs can kind of do prevention, and specialist doctors can only do a reactive medicine, so only to deal with the already emerged problems. So this is something to be handled as well, but that's a real issue.
It would require regulatory change in that
exactly.
sense. Okay. Briefly for Ingrid, and then I don't think we have a lot of time for other questions.
No,
So Ingrid.
just a comment on that, on prevention and person-centered prevention. We have an ongoing project now that many regions are doing now that is providing health dialogues. So all people in a certain age group get an invitation to come to healthcare and to discuss their heredity and also lifestyle issues in order to get the best help to promote their health. And I think genomics is not yet like a standard, I mean, it's not a standardized tool in that process, but some people, you could do your genetic testing yourself, so you can. So some people bring probably that to the table, but it's still, it's a project that are dedicated to personalized prevention by looking at the individual, and that is a promising approach, we think, from the National Board of Health and Welfare and the government, I think, and it's part of our reform towards a more preventive healthcare system.
Yeah, thank you. This is a really good example, I think, and the potential of building in the precision part of it, I think, is also quite important. Very briefly, yes?
Just to say, primary care is key, and training into GPs around what to do when you have a patient coming with some genetic information, with whether they've done it commercially or whether they've done it through a screening. There's been publications on that and the tools for primary care to know how to manage these types of more precision screening approaches is key for moving forward, and that's a gap at the moment.
Thank you. Thank you very much. Thomas, now we've taken like a sequence like this, so you're next. Any brief reflections on the questions I threatened you with before? Affordability?
Yes, on affordability. I think that on precision medicine, if we talk about medicine's pricing, it's really not a different approach than to any medicine. I mean, you have in most countries, have some sort of value-based approach where you do a value assessment of a new medicine. You have an HTA assessment and all of this, and then you have a negotiation with the payers, with the pricing and reimbursement authority. What are we ready to pay for this? And then you arrive at the price, and it's the authority who sets the price. And that goes, of course, also for precision medicine. What might be different is the evidence standards. Do we have all the evidence now? Do we get it later? How do we do that? That's also not necessarily unique to precision medicine.
Also the
but
order
it's
of
also
magnitude
a combination with the diagnostic. And this is, of course, something that isn't always done in sync, because, of course, you need to use these things together. But sometimes, often the regulatory approval of the medicine and the diagnostic is completely different. And in some countries, okay, you have access to the medicine, but not to the test. So then it's or the other way around. And here's also where, or sometimes you have the test, but that's not reimbursed because that's not in the system, and then you get the disconnect. So you need to look at the value of the whole thing, and again, you know, the savings that you can at least in some cases achieve by a more targeted approach should definitely be part of that conversation, because we should look at the total you know, health outcomes and resource constraints on the system.
Thank you. And to be fair, I think we'd need another seminar just on that to go into more detail, which we don't have time for. But these are all really good interventions. I already warned you, we have to wrap up, not only because Helen has to leave, but because I have to present in the plenary, which is upstairs now. So we have a final lightning round, because now I'm putting out on my different hat, and I'm Sarah again. Thinking about the World Health Organization's role and what it can potentially do to support or help efforts beyond the novel medicines platform that we talked about already, or within the novel medicines platform that we talked about already. So from your perspective, what is your one wish from the WHO moving forward in this area? Do you want to start, Sander?
Yeah, sure.
Okay,
so, very briefly, but for preparing the session, I looked at WHO's homepage for information about genetic medicine and how to use it, and there is purely nothing. And so I hope I'm not like the worst searcher in the world, that I didn't find anything. But I think that World Health Organization could be the organization that facilitates the realistic expectations we have in the field, to build a material which is really neutral and realistic, and to guide the field to the direction which really makes sense, so that most people benefit from it.
Thank you.
Thank you.
Guidance and visible guidance. Yeah, easy to find on the internet. Yes, good. Thank you. Ingrid.
No, I got confused when you said that. But from what we want from WHO, I think maybe WHO, but how to clarify and make visible how personalized medicine as a part of person-centered care can actually contribute to equal health. That's I think would be, I mean, I think it's probably more a question of communication, communicate that. And I also encourage you to wait for and look for the policy brief that European Observatory is working on, because I think there you will line out the challenges and the reflection and the wise reflections that policymakers need to do when they direct their future in this field.
Yeah.
So, as you said before, also it's coming soon, and it's done a little bit maybe in collaboration with WHO anyway. So there is a document.
There is a document. It's going to incorporate all of your wisdom from this panel. So we're very grateful for that as well. Thank you, Ingrid. Matt.
Precision medicine is innovation, and not one stakeholder is responsible for the development of innovation and its implementation. So what we need the WHO to do, and I think you're doing it, you're moving in the right direction, is provide the leadership, but also provide the space for multi-stakeholder collaboration from the patient community, from member states, from industry. The whole thing about we need to zoom in on the precision medicine, the medicine bit around affordability and price, to have the discussions to create greater transparency around the pricing and economic models, but also zoom out. We need to look across the field and look at precision screening through the whole care continuum.
Thank you. Loud and clear. Thomas.
Thank you, Joe. I mean, I agree with a lot of what's already been said. I think there is a clear role on the capacity building, on the kind of education, because there is a lot of awareness raising that needs to be done. I think also, you know, all countries, since precision medicine contains so many elements that needs to fit together, you know, you need some kind of plan, you need some kind of action plan. What are we going to do? What's the national strategy? And I think there's a lot of learning here between countries that WHO could facilitate. and help monitor what are different countries doing, what are the good practices, and is there some sort of template for how to guide national initiatives and also help guide to the different pan-European initiatives that are out there. So that kind of coordinating, guiding role, I think would be very helpful.
Thank you.
Yeah.
Last but not least.
So
Helen.
it's practically the same thing. I mean, during the pandemic, we're in this together, and this is not a crisis, but this is demanding as well. So to facilitate collaboration, in short, would be my.
All right. Guidance, easily to find, collaboration, multi-stakeholder forum. I think we have that. And we're very, very grateful to all of you and to all of you for joining us. And we wish you a nice short break and a wonderful last plenary. Thank you all very much.